Well, as I bring this up, you saw this slide earlier. It's one that Michelle Marks presented to the Scoliosis Research Society, and as mentioned, was nominated for the Hibbs Award. I'm going to really present this paper in context of, again, what families are interested in. And I think, framing this question about understanding motion is so important. And I know that you really want to figure out how to quantify what does it mean to have an area of fusion not move versus an area of tether that does when it comes to functional movements and how you live your life. Uh, I think there's sometimes a misconception that fusion removes all motion of your spine rather than all motion within the area of instrumentation. And the idea that tether preserves all motion is not a correct assumption either, as it turns out. But this is obviously an important space, and and work has been done. Dr. Larson presented one of the very first papers radiographically looking at this and identified side bending and forward bending motion postoperatively after tether, demonstrating motion remains within the instrumented segments, which was an important proof that in fact motion was preserved with tether, although we of course thought that that was the case. She was able to demonstrate the magnitude of that effect. And Dr. Samdani's group, Dr. Pays, presented on motion analysis data looking at patients who were in a gait lab setting, bending and measuring their trunk motion. And again, found that there's less motion when you have a fusion than when you have a tether. Trying to strictly quantify that is a challenge, however, and it obviously depends on how much of a fusion you have and how long your fusion is and how many levels need to be tethered. So I'm going to present to you the results of this paper. It gets a little bit on the sciencey side, but I've tried to bring it down to a level we can all understand. And we really want to look at the radiographically measured motion. So this is going to be done comparing patients several years after surgery, 2 to 3 years. They either had a posterior spinal fusion or they had a tether procedure, and we're going to quantify and actually measure in degrees the spinal motion that occurred in various bending motions. So this was data that was collected from 5 of our sites. It was really only for right thoracic scoliosis, so this does not necessarily apply to lumbar curves. And again, the follow-up time is at least 2 years. The idea here is that if we take a radiograph with you bent all the way to the left and all the way to the right, we can measure each individual level and find out the change in angulation between those, between any level or between the entire spine. And in doing so, we can also look at forward bending. So we can look at the flexibility when you bend forward. We looked at 3 regions of the spine: the total spine motion, top of the spine, top of the thoracic spine to the bottom of the lumbar spine. We looked at the instrumented segment, where were the implants? And again, this could be for either posterior fusion or tether. And then we looked at the area below the instrumentation. This is the part of the spine that remains unaffected largely by the instrumentation, whether it's fusion or tether. So it's a really important region that remains, and the function of that part of the spine, particularly if you have a fusion, is critical. And comparing how that changes with these 2 treatments was one of the goals. As noted before, we typically get more correction with a posterior spinal fusion than we do with a VBT. But this is sort of known. And again, if your goal is straightness, posterior spinal fusion is a more reliable way of getting that. Motion. Here's one of the easy take-homes. And again, this goes back to some of Noel's work. The instrumented region, the area where we put the screws, either a rod or a tether. If it's a VBT, your motion is decreased about 50%. So it's not, you don't keep all your motion. The tether has to reduce your motion somewhat to work. But if you have a posterior spinal fusion, your motion is decreased 100%. And I think that is easy to understand. It's one of the basic principles. VBT reduces the motion within the instrument segment about 50%. If we look at overall motion, this may seem really surprising. We did not find a statistical difference, although you can see that VBT motion overall was 70 degrees. posterior spinal fusion motion 63 degrees. That, at least with the numbers we had, wasn't statistically different. But you can see, even if it is, it's a relatively modest difference in the total side bending motion between patients who had a fusion and patients who had a tether. That implies that the segments must be moving a little bit more above and below the area of fusion, because we just said the fusion segment doesn't move. So there is not a lot of difference in total side bending when it comes to the functional movement that we do. Again, side bending is just one movement that we do, but in this case, not much difference. However, in forward bending, there was about a 20-degree difference. So more flexibility in forward bending with VBT versus posterior spinal fusion. This is probably the most important plane of motion that the tether allows, whereas the fusion restricts. And it turns out that this bending movement, forward bending movement, probably much more common than the side bending movement. And so that 20 degrees, may make a difference to people. And then again, if you couldn't touch your toes before, you're not going to touch them after. Does it matter to you? It depends what you're trying to do. But that's the magnitude of the difference. Interestingly, here also in the uninstrumented spine, below the area of fusion or tether, no difference in side bending lumbar motion. It almost doesn't make sense, given that we said you need to have increasing motion to sort of compensate. But no difference in side bending here below the instrumentation. But again, in forward bending, interesting here, the motion below the instrumented segment is more if you've had a posterior spinal fusion. And that makes us think that maybe that's a mechanism that the body is trying to use to compensate for the lost motion that occurred in the fusion above. And it might be that that's too much motion. The body has, designed an amount of movement through the disc that is normal. And so it may be that accentuated motion is actually putting more stress on those segments over time. And will that lead to premature arthritis? We do have a lot of long-term follow-up on thoracic fusions, which show that they do quite well. But there is an alteration in the segments below the fusion, causing them to move more than we think is normal. So in summary, the posterior spinal fusion gets greater correction of the curvature, and the VBT instrumented coronal motion loss is about 50% that of a posterior spinal fusion. And there's modest but measurable differences in the motion. Within the instrumented region, we lose 100% of motion in posterior spinal fusion and about half that in a VBT. And overall total motion, modest differences, slightly less motion with VBT, slightly less motion loss. So more motion with VBT, and the motion below the instrumented segment, really subtle differences, and primarily in the sagittal plane or in this forward bending. And we'll have to sort out whether or not that matters over time in the long term with wear and tear on the disc, et cetera. So we really are trying to get specific evidence regarding bending. And I think this is, again, helpful, we hope helpful information to patients to understand what does it mean when you say it's motion preserving, and how much motion and what planes of motion, because all that matters. And this isn't measuring all the other ranges of motion that we have, twisting and complex movements. And so it's hard to know how this translates to other planes of motion. But hopefully that's helpful. Appreciate you allowing us to share that research study with you.
Great. Thanks, Peter. That was really, really awesome. So I've been told we have time for one question to get us back on track. I think there's a lot of really good questions, so I appreciate everybody for sending their questions in. I'll remind everybody that since the way the laws are, we can't give specific medical advice or care to any individual patient. So unfortunately, we can't answer those questions about your own case. But here's a good question, Peter. What is the pain like after surgery between VBT and a posterior spinal fusion?
Oh, that's a great question. In my experience, we've got great methods of pain control for both operations. The VBT is, quote, minimally invasive because we do these small incisions on the chest, but we're still working inside the chest and we've violated the muscle of the chest wall and it hurts a bit. But we've got good ways to give nerve blocks and fascial plane blocks after either of these operations And for me, the length of hospital stay and the time to recover to get ready to go home is about the same for either operation. It's about 3 days in the hospital, and you should be ready to go home. And so I think from a pain standpoint, I don't find them to be markedly different.